Okay, let's unpack this. Imagine someone in rural Jamaica experiencing a mental health crisis. Who do they call? Where do they go? What's often overlooked but absolutely essential for a thriving community? Mental health. Today, we're taking a deep dive into an incredibly insightful stack of sources about Jamaica's unique mental health care system.
Right. And what's fascinating here, I think, is how Jamaica has developed this distinctly community-based model,
Yeah.
especially, through its innovative use of mental health officers or MHOs. We'll explore how this system works, how individuals access care, and the collaborative spirit that truly defines it, while also, touching on the challenges it faces.
Exactly. Our mission is to give you a shortcut to being well informed on this, from the specific resources available to the nuances of navigating care in Jamaica. We've compiled comprehensive reports, government documents, expert analyses, so you can really understand the how and why behind this, well, this evolving system. So, one of the first things that just jumps out from our sources is Jamaica's commitment to a community-based mental health care model. This seems really distinct. Let's explore why.
Yeah, if we connect this to the bigger picture, this decentralization, moving care into the community, it's quite progressive. It means mental health support isn't just sort of locked away in large institutions. It's integrated more into people's daily lives, their local communities.
Right.
And the deeper insight here, I think, is how this model inherently tackles some common barriers, like physical accessibility and the very real stigma that often comes with traditional psychiatric hospitals. Makes care feel more approachable.
Okay, so approachable and community-based. Now, our sources repeatedly call these MHOs the backbone of community services. That's a strong term. Who are they exactly? What makes them so pivotal?
Well, MHOs are specially trained nurse practitioners, and they really are crucial for quality service delivery. They conduct most of the primary care clinics, they respond to emergency calls, make those vital home visits, and they also have this unique legal designation. They can initiate detention under the Mental Health Act. They can even advise, primary care doctors and hospital physicians.
Oh, wow, okay.
Yeah, their role is really multifaceted. It combines clinical care, legal authority, and that community presence. That's what makes them pretty indispensable.
So understanding MHOs are central. Let's look at the physical places. Where do patients actually get care in this system? And how has the role of, say, the traditional psychiatric hospitals changed?
Right. Well, Jamaica's largest psychiatric hospital, Bellevue in Kingston, its role has shifted. It now primarily functions as a custodial facility for over 600 indigent patients, mostly over 65. It does still have about 100 acute beds for the Kingston area, though.
Okay.
Then you've got the University Hospital West Indies, UHWI, also in Kingston. That has a 20-bed psychiatric unit for acute cases. The average stay there is around 15 days.
Shorter stays then.
Generally, yeah, for acute care. And out west, Cornwall Regional Hospital serves the rural regions. It technically has a 60-bed unit, but often, due to staff shortages, only about 30 beds are actually in use.
Staffing challenges.
Exactly. But here's something really unique to Jamaica. It really highlights the community model. Over 60% of acute admissions, they're actually treated in general hospital medical wards.
Like not psychiatric wards.
Right, general medical wards by GPs and nurses, but under the supervision of community psychiatrists and the MHOs.
That is a different approach. Shows a real shift away from relying solely on those big central institutions. Okay, so it sounds like the MHOs are central, but mental health care is rarely a one-person show. Who else is on the team? Who's needed to make this system really comprehensive? And are there, gaps in who's available?
Good question. So regional teams are led by psychiatrists. They provide that specialized medical oversight. Then you have psychiatric aides supporting the MHOs, especially like during home visits and on those on-call teams.
Okay.
Clinical psychologists are increasingly involved, providing assessment and psychotherapy. That's thanks to some recent postgraduate training programs. But MHOs do note they need more psychologists to broaden the therapeutic options available.
Right. Therapy access is key.
Absolutely.
Okay.
And social workers are also crucial. But again, NHOs have specifically flagged a need for more of them, particularly in the community, to help patients with, basic but vital things like housing, financial aid, childcare issues, things that can seriously block recovery if they're not addressed.
Practical barrier.
Exactly. And finally, you have the general practitioners, the GPs. They treat moderately severe mental illness, and they collaborate really closely with MHOs on stable, severe cases. So the gaps, they often lie in the sheer numbers needed, especially for social workers and specialized therapists.
Makes sense. But it's clear from our sources that support isn't just the formal medical system. There seems to be a pretty robust network of community support crisis hotlines, too.
Oh, absolutely. For immediate help, there are several public crisis hotlines. The Ministry of Health and Wellness has one, 888-1-LOVE, that's toll-free. There's also the Mental Health and Suicide Prevention Helpline at 888 New Life.
Good to know those numbers.
Yeah. And for kids and teens, SafeSpot offers 24-hour confidential counseling. And younger people can use the You Matter chat line through WhatsApp. Beyond those, you find hotlines for domestic violence, child protection, like the Child Protection and Family Services Agency, the Victim Services Division, and crucially, there's this whole network of NGOs and community support, things like private halfway houses, church groups offering counseling, rehab, groups like Rise Life Management Services, Equality J, Jam Hand, Cara Mensa.
Wow, quite a list.
It really is.
Yeah.
It speaks to this idea that mental health is, well, it's seen as a community-wide responsibility.
Okay, so if someone in Jamaica needs help, how do they actually get into the system? What's the typical path? How do referrals work, or how does someone start the process?
Well, the system's designed to be pretty accessible, very community-oriented.
Yeah.
And it often leverages informal relationships. Referrals can come from all over. Social workers, probation officers, family members, prenatal clinics, GPs, police, courts, even self-referrals.
So quite flexible.
Very. These informal networks, built on direct contact between the MHO teams and other services, they can vary a bit by area. It highlights the kind of responsive nature of the system. But usually, most individuals are initially seen directly by an MHO or maybe a crisis response team, or they might show up at an accident emergency department.
Right. That brings up a really important question. What happens in an actual emergency? How does the system handle an immediate crisis?
Okay, so emergency calls. They get directed straight to the MHOs. If a call comes in after 5 p.m., it goes to the MHO who's on duty. They'll discuss the situation with the carer or relatives first.
Okay, try to manage it remotely first.
Sometimes. It could lead to advice over the phone, or it might trigger a visit from the on-call team. Now, that team is usually an MHO and maybe 2 to 4 psychiatric aides. Interestingly, doctors aren't typically part of these immediate response teams. Yeah. And they're also developing mobile response units with a similar setup, trying to bring that immediate response right to the patient's location. So when these teams visit and assess someone, there are generally 3 main outcomes. 1, the patient might be taken to the nearest hospital. 2, they could be given treatment right there at home. Medication might be started, liaising with the GP.
Treatment at home. Oh,
Or 3, if maybe no immediate treatment is needed, they offer support and counseling to the responsible carer. Complex cases or situations needing medication changes, those always get referred up to a psychiatrist.
it really sounds like hospitalization is maybe not the last resort, but certainly not the first option in this model. Why is community care preferred so strongly, and when do patients end up admitted?
That's absolutely right. Hospital treatment is generally quite rare. Most people are treated within the community. It's usually recommended for patients who are highly agitated, or maybe those who lack family support situations where home treatment just isn't feasible.
Makes sense.
Police might help with transport to the hospital, though the sources say sometimes they can be a bit reluctant.
Right.
The average hospital stay for an acute case is about 2 weeks. Once someone is stable, they're discharged back to the care of the MHO in their community. And that discharge includes family counseling on continuing treatment, and prompt follow-up appointments are set up.
So it's a quick return to the community if possible.
Exactly. The whole approach aims to minimize disruption to the patient's life, foster a faster return home. And the continuing care, for patients who have seen a psychiatrist, that's then provided by the MHO, oft through home visits, especially someone who lives far from a clinic or doesn't have much family support. It just underscores that ongoing integrated role they play.
What's really striking here, listening to all this, is the huge emphasis on collaboration. It seems to underpin the entire system. And the MHOs, again, they seem to be right at the center of that network.
They absolutely are. MHOs are that crucial link. They're sharing care with the regional psychiatrists, the district medical officers, and really importantly, the patient's family. They bridge primary and secondary care, they provide direct care, and they liaise with other clinicians, with hospital teams, and like we said, they advise other doctors too.
So care isn't siloed.
Not ideally, no. It's meant to be a shared responsibility. And that deep integration with primary care is key. Remember, Jamaica's mental health services are deeply embedded within its primary healthcare system. GPs treat those moderately severe cases. They work with MHOs on stable, severe cases. And they refer the more complex stuff to the mental health clinics.
Okay, so this deep integration, How does that actually play out for the patient's family? What's their role, and why is it so critical in the Jamaican model?
Yeah, that's a great point to connect. If we look at the bigger picture, these family support networks are just absolutely vital for community care to work in Jamaica. Families actively help with home treatment. They help make sure medication is taken. They monitor the patient's mental state. The system, really, by its design, relies significantly on this family support.
So it leverages a cultural strength,
You
almost.
could definitely see it that way,
Yeah.
yeah. It highlights something fundamental that's leveraged for healthcare delivery.
And it's clear it's not just healthcare pros and families working together. Our sources talk about a much broader, multi-sectoral approach.
Indeed. A truly comprehensive response needs partnership across loads of sectors.
Yeah.
Health, yes, but also education, employment, the judicial system, housing, social services,
Yeah.
plus the private sector and NGOs.
Hmm.
The Ministry of Health's mental health unit is actively involved in these kinds of collaborations.
Right.
And the WHO even recommends fostering collaboration with what they call informal providers, people like religious leaders, faith healers, teachers, police officers, to really expand the reach and the support network.
That makes sense, building those wider connections. But while this collaborative spirit sounds great, really holistic, do the sources mention any challenges? Like when one role, the MHO, becomes such a critical hub for so many things, or other areas where collaboration maybe hits some snags?
Yes, absolutely. There are nuances and challenges. For instance, some doctors, particularly in hospitals, might prefer dealing only with other doctors, which suggests, a need for maybe greater acknowledgement sometimes of the MHO's expertise and their comprehensive training.
Okay, professional recognition issues.
Sometimes, yeah. And the MHOs themselves, they've flagged that significant need for more social workers to help with those practical issues, housing, finances, childcare that are currently, getting in the way of patient recovery.
Right, the resource gap again.
Exactly. On a more positive collaboration note, though, police involvement is becoming increasingly necessary, especially in high-violence areas. They help calm aggressive patients, assist with hospital transport, and training the police for these situations, that's proven feasible and effective. So that's actually a promising example of intersectoral work.
So progress in some areas, challenges in others.
Pretty much. It's a reminder that even, strong systems have areas that need ongoing growth and refinement.
Okay, so understanding this unique structure, these key players,
Yeah.
how does someone practically navigate the system in Jamaica? And what about their rights within all this?
Well, services are highly decentralized, organized by region, like we said. Mental health is integrated into primary care, aiming for universal health coverage. General hospitals, the psychiatric units, they offer 247 emergency services, and it's the MHOs directly managing that crisis response.
Uh-huh.
A really key piece for navigating this is the Charter of Patients' Rights. It's there to ensure individuals feel empowered in their own care journey.
Right, you mentioned that charter. Our sources highlight it as incredibly important. So for anyone listening, navigating this system, what are some of the key rights they really need to know about?
Okay, the Charter covers several crucial areas. First, the right to access appropriate health services. Then, the right to information about your health, your treatment options, and importantly, the right to be involved in making decisions about your care.
Participation, okay?
Yes. You also have the right to informed consent. That means getting a clear explanation of your condition, the proposed treatment, and crucially, the right to consent or to refuse that treatment.
Consent and refusal, critical.
Absolutely. Confidentiality and privacy are guaranteed. Your personal health info should be kept private. And finally, you have the right to give feedback and to have any complaints addressed properly and in a timely way.
So it's designed to give patients real agency.
That's the goal, yes.
That's a strong foundation of rights. But let's talk practicalities. Access isn't just about services existing, right? It's about affordability, practical stuff. How do financial concerns, maybe even social stigma, affect someone's ability to actually get the care they need?
That's a critical point, and it really it humanizes the challenge. While the mental health treatment itself is generally free, there is that small charge, about US $2,
Yeah.
for prescribed medications.
Okay.
Though the long-acting injectable meds, the depot injections, those are free. But interestingly, medication needed to counter side effects from those injections, that's not free.
Complex.
It is. Now, there's government assistance available for low-income patients, but frontline staff report that very few people actually ask for it.
Why is that?
Stigma, mainly. The stigma associated with being identified as eligible or needing that kind of help, and also the lack of privacy in some clinic settings can be embarrassing for people. It leads some to avoid clinics altogether if they can't afford the medication fee. So families often step in and cover the costs.
Wow, so families bear that burden too.
Often, yes. And add to that, the availability of medications is limited. Older antipsychotics are usually available, but the newer, often more effective but more expensive ones. Limited availability.
Right.
So even with the structures, these very personal, practical barriers, cost, stigma, privacy, availability, they can totally change how or even if someone accesses care.
So despite the strengths of this community model, our sources are pretty clear there are significant gaps. What are some of those persistent challenges? Why do they stick around?
Yeah, indeed. A major one is for common mental disorders, things like anxiety, mild depression. There's very little, almost no dedicated community service for these, despite how prevalent they are.
That's a huge gap.
It is. Rehabilitation services also face big challenges. There's no real strategic development, mainly due to lack of funds and a scarcity of occupational therapists.
Mm.
Where rehab exists is primarily at Bellevue and UHWI. There's some private halfway houses, but families have to pay for those.
So access is limited and often costly.
Exactly. There's also no funded national strategy for specialized areas like old age mental health or forensic mental health that's dealing with individuals in the legal system. And homelessness is a major, major concern. About 2% of the mentally ill population is homeless, which makes up something like 60% of Jamaica's total homeless population.
60%.
Yeah.
Oh.
And government shelters for this group are basically absent. It relies heavily on charity, NGOs, church hostels.
That's a heavy reliance on the third sector.
It is. And underlying a lot of this is the workforce challenge. There's a significant brain drain. Highly qualified nurses, including MHOs and psychiatrists, leaving for higher income countries. Better salaries, maybe better quality of life. It seriously undermines the system's capacity. And just quickly on the legal side, the Mental Health Act from 1997, it details compulsory detention, but it limits it to 14 days. That's different from some other places with longer involuntary periods. The Mental Health Unit is recommending amendments to align better with the UN Convention on the Rights of Persons with Disabilities, pushing for more of a human rights focus.
Updating the framework.
Right. And there was a notable test case involving an MHO charged with battery. It really highlighted the need for a clear code of conduct and better education on the Act for practitioners themselves. Shows that legal frameworks need to evolve, too, to support the system effectively.
Okay, so bringing this all together for you listening, what does this mean if you or someone you know needs immediate help or wants to find support in Jamaica? Our sources gave us a really comprehensive list, and we've kind of distilled the key ones for you.
Right. For immediate, urgent support, you can call the Ministry of Health and Wellness Mental Health toll-free helpline, 888-1-LOVE, that's 663-5683, or the Mental Health and Suicide Prevention helpline, 888-NEW-LIFE, which is 888-639-5433.
Got it. 888-1-LOVE and 888-NEW-LIFE.
Exactly. For children and teens needing confidential counseling, SafeSpot CHA is available 24/7. The number is 888-SAFE-SPOT 7233-7768, or they can text 876-439-5199.
Okay, options for different age groups and communication styles.
Yeah. You can also reach out directly to the Ministry of Health and Wellness Community Mental Health teams. There are regional contacts available for those. And don't forget the specific helplines for domestic violence. They have separate ones for female and male callers. Plus, the Child Protection Family Services Agency, CPFSA, and the Victim Services Division, VSD, have hotlines too.
Lots of specific supports there.
Definitely. And for more general support and services, you could look into organizations like Rise Life Management Services or the Equality JA support lines. And remember, those community mental health officers, the MHOs, they are really your frontline responders.
Sure.
Direct care, home visits, first point of contact in a crisis.
The backbone.
The backbone, exactly. There are also those private halfway houses we mentioned, though remember, fees usually apply and families often pay. And the church and NGO hostels offer support, particularly for some homeless individuals.
Okay. And as we discussed, understanding your rights is just crucial when you're navigating any healthcare system. So let's quickly recap the key takeaways from that Charter of Patients' Rights.
Right. So your rights include access to appropriate services, communication, and participation in your care decisions, confidentiality, privacy, and being treated with dignity and respect. You also have the right to safety, the right to informed consent for treatment, meaning you understand and agree, and the ability to give feedback and make complaints.
And responsibilities too, right?
Yes, the Charter mentions those too. Things like providing accurate medical history, letting providers know about changes, following instructions, keeping appointments, behaving respectfully towards staff and other patients, and protecting property. It's a two-way street.
Good reminder.
And just a few more resources people might find useful. There are local acts, like the Mental Health Act itself, the Data Protection Act, international guidelines like the UN Convention on the Rights of Persons with Disabilities. For personal well-being, there's even a Jamaican mental health journal called So Ya Good Do by Alicia Edwards Grant.
Oh, interesting.
Yeah. And professional groups like the Jamaican Psychiatric Association and the Jamaican Mental Health Advocacy Network, JMHAN, are key resources too for professionals and the public.
Okay, quite a toolkit there. So we've taken a really deep dive into Jamaica's mental health care system today. And what truly stands out, I think, is its resilient, really unique, community-focused approach, with those mental health officers right at the heart of it.
Indeed, it really raises an important question, doesn't it? How a system facing significant resource constraints, challenges like workforce flight, how it still manages to deliver care primarily within communities, heavily relying on family support, that network of informal collaborators. It's a powerful testament, I think, to adaptive, human-centered care. It's definitely a model worth deeper consideration.
So what does this all mean for you listening? Maybe consider this. In a world grappling with rising mental health needs, Jamaica's model really emphasizes integration into everyday life. It highlights the crucial role of community, of family. How might this homegrown approach relying so much on relationships, on these frontline MHOs, rather than just specialized institutions, how might it offer lessons for other mental health care systems around the globe, especially perhaps in resource-constrained environments? Lessons about true accessibility, about human connection, something to mull over until our next deep dive. Thanks for listening.